Sina, I'm very happy to see Varsha and all the rest of your team, and most importantly, the wonderful students here. I've been coming to IIM Raipur and visiting the campus even when we started off initially. Is there a... I'll speak from here. It's okay? Thank you. So, I had the honor of visiting the institution previously as well, but I'm very happy to see the development which has occurred and the changes and the modifications and how the campus has come up beautifully, as well as this wonderful auditorium. I know that IIM Raipur has got a huge respect now in terms of the quality of the products which are coming out, and it's one of the sought after AIIMS, now IIT and IIIT, HNLU. We have ushered in actually a new era for higher education in the state of Chhattisgarh, and we're really happy to contribute to that. So my topic again is a wonderful topic which has been given to me. What you can see is this is the main hospital building. It is a 1,000-bedded hospital, and this is the medical college. So it's got a sprawling campus of 64 acres for the medical college, hospital, and other facilities, and a 40-acre campus for the residential area. We've also got 50 acres in IIM Raipur, and we hope to develop it in the coming years. That's what I was discussing with Professor Sinha. He was the flag bearer who came here for the first time, and it has that IIM Raipur has been connected. So thank you very much, sir, again for inviting me for this wonderful series of Gyan Varsha. It makes so much sense to see and honor academicians, industry specialists, and the contributions they make towards the country. Of course, like sir has rightly mentioned, sometimes at the cost of their own family, but the sacrifices have to be there if you want to achieve something. So thank you very much. A topic which was given to me by sir is something which is very, very close to my heart again, operation theatre and surgery room. I think my wife will vouch to me that in the last almost 35 years, I'm a place where one feels very comfortable, because it's a place where you can really give the best for the society and for the patients who need it the most. So what is an operation theatre or an operation room? I won't make it theoretical, I'll have a lot of pictures to show you so that you can really enjoy the presentation. So it's a facility within a hospital where the surgical operations are carried out, and very importantly, aseptic environment. So that asepsis part, the infection control part, is always highlighted, especially in terms of patient safety. So it was used to be called an operation theatre, OT for short, but in many of the American serials or British serials you must have seen OR, operation room, that's the term that they use. And it used to be in the past what was a non-sterile tired theatre in the past, where it was known historically, it was not sterile, and of course now it's sterile, it's very important. It was more like an amphitheatre in which the students and spectators could watch the surgeons perform the surgery. Something like that, a tired system, and surgeon with his team down here. I'll show you this image, you can see how it was historically. The surgeons used to operate, and everybody used to watch, and they would learn the steps of the surgery. That was so interesting. That's how they were trained. These were about almost 100 years ago. You can even see in one of the institutes in Padua, it's a famous hospital in the University of Padua that you go to work, and this is still preserved, where the operations used to be conducted, and the people would stay here and listen and learn surgical steps, especially the newer generations, the younger generations. Again, Dr. Morton was the first who gave ether for a patient of a neck tumor. I'm also a neck tumor specialist somehow, and that's how I know he was giving, the first time I think I was giving anesthesia. And you can see how carefully they are all observing it and learning it. This was known as the ether dome in 1846. It's still preserved, and this is how it looks now. It's part of the museum now. And that's why I think what we do is going to become history. So we always learn, we evolve, and the surgical theatres are something which are so important for all of us. This is how a modern operation theatre looks, and this is one of AIIMS Raipur. We have 28 such modular operation theatres, whether it is for doing emergency surgeries, or which are elective surgeries, or any other surgeries which are planned. So this is how things have changed, and I'll just come to what all is there. So these are the modern operation theatre, gamut of devices. You can see me using a microscope here, then this is a laser, carbon dioxide laser, we have to use these special glasses. You'll find multiple monitors over here, lots of gadgets and devices, but everything is networked. You can sit in one room and observe it live in another room, and so on and so forth. You can record it, you can demonstrate it, and even 3D vision is now available. And everything is possible, sir, because of the technology advancements. I think cutting-edge technology has the biggest role in medical field, because that's where I think the public interface is the maximum, whatever you will do, I think from bench to bedside, the best place to apply it is in the hospital or in a clinical setup. So what do we have in the OT components? We have the OT, we have the operation theatres, we have the pre-operative area, the post-operative area. So normally the patient comes from the ward to the pre-operative area, then would move to the operation theatre, then would get operated there 2 hours, 3 hours, whatever kind of surgery, then move to the post-operative recovery room, and then finally go back to the ward. So this is the usual cycle. So again, this is a pre-op hold area where we bring our patients. You can see there are a large number of beds. All these are kept very neat and clean. Patients are brought here. Once their turn comes, they are wheeled in for the operations. And this is after they have come back from the hospital, from the operation. You can see there are monitors, there are gadgets, but we keep it very neat and clean and cluster-free. So just never, you won't get that feeling of claustrophobia. And patients are kept at a distance so that the infection rates are very less. And this is the actual operation theatre. Patient comes in, you find the anesthetist, you first evaluate the team, you got the OT technicians, you have the anesthetist, you have the nursing staff, and they will first have to give anesthesia to the patient, which is either general anesthesia, where the patient sleeps during the surgery, or spinal anesthesia. Patient is awake but doesn't feel the pain, especially in the lower part of the body. And this is how we put in the tube after, and then it's gradually step by step thing. And again, these are parts of the operation theatre where once the patient is anesthetized, we start bringing in the microscope and the endoscope and the laparoscope and other devices. So this is one thing that I'm using. This is the endoscope over here, and we are all watching it, the surgery which is happening on a screen. So we do, what again trying to tell time and again is the role of the technology which has made a difference. This we would have to use a headlight, a bulb and see things inside. Now we can see everything what is happening, the whole world can see it. Somebody in the US can also see it, or in Germany what we are doing here live. And we can discuss with each other, it can be recorded. It's really amazing how technology plays a role, especially in the medical field. And I think that's why we must all team up together. The medical specialists, the technologies, the management specialists, everything should come together. This is scrubbing area. Once the surgeon or the I'll show the video in the end. The surgeon, the anesthetist, the nursing staff, they have to first come here and they have to scrub, and then only they are clean enough to go inside. These are sliding doors, you just keep your hand, the door opens and you move inside. And these are where all the equipment are kept. These are endoscopes with their, you can see that they have got these casters so you can move around with the equipment. These are different types of fiber optic endoscopes and screens. They are usually kept in the store area and whenever required, otherwise it will be all clustered inside, claustrophobic for the operation theatre. So we bring out one equipment and another as per requirement. So what's the OT team? The OT team is a huge team. It's not just the surgeon. The surgeon is of course part of the very important part of the team. But you have the OT technicians, you have the doctors, which could be surgeons and anesthetists. You have the nursing staff. They are very, very important. They make all the preparations in the morning to ensure sterility of the operation theatre and in the pre-op and post-op hold areas. The scrub nurse, the circulating nurse, the pre-operative nurse, the post-op nurse. So it's a huge team. So the scrub nurse is the one which assists the surgery. The circulating nurse is the one who is free, giving us instruments and equipments as we might require. And there are paramedical staff. They have been very important. They have to ensure the upkeep of the equipment also. And then there's a huge anesthetic team. We have professors and faculty members in anesthesia, there are doctors, senior residents and junior residents. So as you can see, this huge team, all of them working together. But there are zones of sterility. And the most important is of course the operation theatre, which has to be kept ultra sterile. You don't want infection, especially in most of the major surgeries which are conducted. Otherwise the patient's recovery and everything that is delayed. So most important, patient first enters into the pre-operative area, the doctors also come over there. That is sterile but less sterile. Then you have the corridors in the post-op area. Most sterile area, zone 1, is the actual operation theatre. Naturally it will be the most sterile area. So this is the pre-operative area, which as I said is the zone 3 along the corridors. Then we have the zone 2, which is actually the OT corridor in the post-operative area. And then you've got the zone 1, which is the sterile zone, which is the most important. As you can see, these are the operation theatre tables. These are all electronic and hydraulic. You can get them up and down, raise the head end or raise the foot end as required. These are pendants for the oxygen and various gases and electrical connections. These are the anesthesia workstations from where actually the anesthetic gases are given. There are the monitors. Then there are top lights over here, the LED lights which bring light on to the patient directly. So as you can see, the whole thing is very well organized. So, but there are OT safety standards, and you know the National Accrediting Board for Hospitals, NABH, has guidelines for at least our country, and air changes have to be there in the OT, at least 20 per hour, and there has to be an air velocity which is unidirectional. So air comes in a laminar flow starting from the top, coming to the operation table and then going away. So that laminar flow is maintained so that infection rates are as less as possible. And a positive pressure is kept in the OT so that no outside air enters inside. So it's only inside air which will go outside. And very important is, some of you engineers, you must be knowing about the HEPA filters, which are the high efficiency particulate air filters, which are very important in the AC ceiling so that they filter out to 99.97%. So this is just the supply of the air. It comes from the top. This is the OT table, patient lying here. Air comes and finally moves away, maintaining the sterility at all times. Again, very important is to maintain the temperature and humidity in the operation theatre. It is very important for the patient safety. If it becomes too humid, then the infection rate is higher. Bacteria are likely to multiply. So, and even for the comfort of the staff, very important to maintain the temperature around 21 to 24, whatever is the usual temperature range, and about 50 to 68% humidity. So, what are the types of the operation theatres? You have the major operation theatres where most of the major surgeries are conducted, whether it's abdominal surgery, head and neck surgery, cancer surgery, ophthalmic surgery. But there are minor OPs also. Small procedures are done. You go for a dressing or suture removal, which will be done as a minor OP. You've got an emergency operation theatre. In the night also somebody would have a fracture or some injury, and immediately the patient has to be wheeled in to the operation theatre. The main operation theatres will be closed, but the emergency OTs are open 24/7. So that immediately patient again, but the protocols have to still be maintained. Labor room, again, this is separate where the deliveries are conducted for the patients. A robotic suite, because separate equipment means separate needs. So you require more trained personnel, more space in the operation theatre, which can then be done. And always, when you have transplants or kidney transplants or corneal implants, we're doing so many other surgeries, where you have to be having ultra sterile, so that there is no infection, so the success rate of the surgery is the maximum. Again, showing a setup where you got these huge microscopes, and they give you 3D vision. Everything can be recorded, and the same thing can be visualized on the screen by so many people. So these are the modern gadgets and devices that we are all using. Now, this is the emergency of. I was just showing you those were the areas where the elective procedures were done. But this is where the emergency OT complex, and this is, believe me, as good as the main OT complex, where patients are again given. You can see that hardly any difference, the same gadgets and same monitors, and a very good OT table where the patient comes. But here the time elapses as soon as the patient comes, the vitals and all those investigations are done quickly, and patient is wheeled into this emergency operation theatre. And once the procedure is done, the patient comes out to the recovery room, and patient is never left unattended, especially in the major cases. Monitoring has to be done, and one should remember that whatever gadgets you have, it is the people over there who are most vigilant. They are the ones who are most important to manage the patient in the post-operative unit. So what are the various surgical branches? I mean, you can see that you must be aware of general surgery, ophthalmology, ENT surgery, orthopedics, cardiac, plastic, surgical onco, surgical gynae, neuro, neurology, dental, and more subspecialties like transplant surgery, bariatric surgery. More and more are opening up. These are the usual main branches where you find operation theatres in the large, at least in the larger hospitals, the larger teaching hospitals. Now again, coming to one of the management points, we have to ensure safety at all times. Safety and sterility was one aspect, but at the same time, we want safe surgery and discharge for the patient. So the management parts are also very important, and that is the reason I will be discussing about the checklist. You know that in the pilots have the checklist so that they don't make an error. So every step is double checked by a team only to ensure that yes, then you can move the next step. And the same checklist which were created for the pilots are now also created for the surgeons. In a way, there's a lot of similarity between the job that a pilot does and a surgeon does as a team. And those checklists are very important, starting from patient admission, pre-operative workup and planning, pre-anesthetic check-up with the anesthetist checks for blood pressure, blood sugar, and etc. You have to make the operation theatre list for the next day or the coming days. Consent, I'll be touching on this quickly. Consent is very, very important. The patient and relatives have to understand the surgery. the checklist again, as I mentioned about the preoperative and surgical checklist, the anesthesia checklist, all the equipments, you cannot have an equipment then non-functional. You better check the equipment 1 day before, 1 hour before shifting the patient to the operation theatre. Sometimes there are special equipments, whether robotic surgery or laser surgery. You have to ensure that all that special, defibrillators are there. These are all devices which are used to aid the surgery. And it's best to check the equipment well beforehand before the patient is shifted inside. Post-operative monitoring, I told you, there are a large number of gadgets and monitors now. And this COVID pandemic taught us how the monitoring part is so important with the sensors and gadgets and devices now available. But the human element, whether for surgery or whether for the monitoring, is still very important, and the doctors have to be very well trained as well as the nurses and technicians. And then of course there is the standard of care in the ICU or the ward, daily rounds, like as sir was just discussing. You can't operate a patient and not go even if it is Diwali day. If you have operated the patient 1 day before, you have to go and see the patient next day morning, next day evening. It is your responsibility, and I think all the best medical professionals would do that. Similarly, once everything is fine, the patient also asks us, now everything is fine, when will I go home? So when to remove the sutures, when to come back again, all that has to be told along with the follow-up care. So you can see that right from patient admission to finally follow-up care, it may run for weeks together, sometimes months together, even preoperative working and planning. For an elective procedure or a planned procedure may take longer, but an emergency procedure, everything has to be, the same thing has to be, in a very short span, it has to be done. So as I was talking about elective admissions, for the elective and planned surgeries, for example, a patient has a gallbladder problem or a cataract problem or a problem related to hearing for which surgery has to be done. So that's a planned surgery. It can be planned over a period of weeks, months, depending upon the fitness of the patient, availability of the surgeon, date, time, etc. And date can be given. Emergency for acute and life-threatening conditions. Somebody has a pain in the abdomen, a lot of pain, acute appendicitis, somebody suffers a road trauma, head injury. So these patients need immediate care. And for that, admission has to be instantaneous. So the evaluation is always done by the clinician first. Equipments and devices are attached, but a clinical evaluation by the team, doctors, nurses is very important. Various tests, diagnostic tests are conducted. We make a diagnosis. We call it as a provisional diagnosis once the patient has come. But once the investigations are available, we will have the final diagnosis in due course. Plan the surgical procedure well. You have usually a team, a senior along with his team who decide with it. And then with other surgical teams, you finally sit. Sometimes we do cancer surgery, but we also require plastic surgery to come and help us to doing the remaining part of the surgery. So we sit with them and decide the date of the surgery, especially along with the anesthetist. So that is why we came to the date of surgery. We don't want to delay wherever, even if it's an elective or planned surgery, everybody wants to get free with it. For example, as I mentioned, cataract surgery or surgery for hearing, they want surgery to be done as early as possible. So that is true, even if it is a planned surgery, people want it according to the convenience, earliest possible date, optimized. So sometimes when you call the patient for surgery, for example, any cancer surgery, you also understand he's also having diabetes which is uncontrolled, or a blood pressure or cardiac issue. So that has to be optimized, treatment to be given for that as well, and only then surgery is done. So that availability of OT personnel and patient factors, sometimes the insurance and where the patient belongs to. Sometimes patients come to AIIMS Raipur from very long distances. I think it is very important on humanitarian ground to address those patients first. And there's also a concept of daycare surgery. Smaller procedures can be done. In the UK, there are separate operation theatres and wards for daycare surgery, and a team looking after it. The patient comes, investigations are done beforehand, patient undergoes the surgery and kept there for about 24 hours, or the same evening patient can be discharged. So we have the concept at our place also, but many times patient comes from a long distance, and then it's better to admit them for a relatively long period. I've already talked about major and minor surgery. So major surgery is usually those which last longer, which require general anesthesia, will require further monitoring. Minor surgery is usually a small minor procedure, a small void, nick to be given, and few sutures for a cut. These are minor procedures usually done in the local anesthesia. So these are the workups which have to be done, the blood tests. And if you're doing major surgery, you also require further investigations. You know that if somebody has a tumor, then you also require CT scan, MRI scan, and a PET is a positron emission tomography CT scan, chest X-ray. So depending upon the needs of the patient, the investigations have to be tailor-made. So we have a set of investigations which are the specific tests, which are for that particular condition, and more general like the blood pressure, blood sugar would have to be done. and then we check for diabetes, hypertension, cardiac disease, and blood. You have to arrange the blood. Many of the major surgeries, especially cancer surgery or gynec surgery, is going to require blood also. We keep the blood ready. So the plan of the surgery is the least morbid surgery providing the optimal cure. So the care should be the best, trauma should be the least, and in a relatively short time, so something which is cost effective also, so that more patients can be given the treatment. So this is the usual workup chart that we have. These are the investigations which are conducted, the test which is conducted. This is the CT machine which we have, so those tests are done especially for the cancer patients. These are the kinds of, this is the tumor, large tumor over here you can see. So these investigations help us to do a proper planning of the surgery and subsequent management of these patients. So this is the checkup I mentioned the anesthetist has to do. One part the surgeon does. There's another part which the anesthetist also has to do, because he has to give the anesthesia, he or she has to give the anesthesia. So they check it from their point also. How fit is the patient to give general anesthesia? Are there any other medical conditions that the patient has? And finally, they also will check, say that yes, the patient is fit, we can go ahead and give general anesthesia or spinal anesthesia. And they will also put their notes for that. And this is their notes. So they have been mentioned about everything. And finally, they will say, yes, the patient is fit to be given anesthesia. You can call the patient on such and such day. So then we have to make the OT list. Everything is done. The surgeon has seen the patient. The anesthetist has given a fitness and clearance. Then we have to make the OT list. Is actually list where the names of the patients are there, the date is mentioned, the type of surgery. So you have to, whichever are the planned cases, what is the disease severity, extent, duration, patient waiting time, everything has to be mentioned over there. And there's a lot of discussion which occurs. It might look very simple, but major cases, a lot of discussion, sir knows that we have discussions in the OPD, then we'll have discussion in the radiology area, then in the OT actually, when before the surgery also you sit and you take your final decision. This is usually for major cases. For minor and routine cases, so much will not be required. But importance is given to major cases. Which one do you keep as the first on the OT list, for example? The very important case which is going to go longer, or a small child has to be done first, or the one in which the anesthetist feels that there is a lot of difficulty which is anticipated in the post-operative period, management of blood pressure or airway, these are done first. So all that has to be done. And then this is the actual operation table, one of the that Dr. was given. So the name of the patient, age, sex, what is the diagnosis of the condition, which is the procedure which is going to be performed under general anesthesia, which ward, and how many blood needs to be arranged. So each and everything is checked, double checked, 3 people, and finally it comes to me, and still I might find some error and get it corrected. So it's actually a very rigorous cycle which one has to do on a daily basis. And then of course consent. This is very important in today's. You people understand the value of consent. Our country is also, more and more people are getting educated and aware. They're aware of the rights, and they should be. This all helps. This feedback helps us in giving the best results for our patients. So the consent is a medical legal document, and it has to be in the patient's own language. So if the patient understands Hindi or Gujarati or Bengali, you have to explain in that language. You have to get it written in a bilingual setup, because it's a legal document and it's going to be used in future also. And if the patient has any doubt, that doubt also should be mentioned and signed accordingly. There is a special consent, especially if the pediatric patient or a very elderly patient who does not know, not able to speak, then the relatives are allowed. So there's a lot of, the law is very crystal clear, and I think that makes our job much easier. Sometimes we get head injury patients which are lying on the road and brought by the police. For them also there is a system, and we can still do their management along with the rules which are available. So the consent, as I mentioned, should be bilingual, but definitely explaining everything in the patient's own vernacular language. There are times when you have to take a high-risk consent, especially if the patient has got renal disease, cardiac disease, and is going to undergo a major surgery, goes on for hours together. So all that has to be done, date time recorded. Sometimes even nowadays patients, their videography is also done so that you keep it as a record for medical legal purposes. And this is the consent form, as you can see, consent form and Sahmati Patra. So it will be in both the languages, and we take it in both the languages from the patient. Again, bilingual, every line is clearly mentioned, every page has to be signed by the patient, the relative, and the doctor concerned. So it's not just that you go and do the surgery and come out. Every document is relevant, important, and to the rigorously followed. So again, how we take the consent, signature of the patient, signature of the witness, and signature of the healthcare provider. every document is accordingly double checked. So these are the checklists, and I think since these checklists have come up, the errors in the operation theatre or management of patients have come down. So I think that's where I think management part comes up, where following the system, following SOPs and guidelines, one thing is creating those guidelines, and their guidelines are created based on proper feedbacks. And the next thing is to apply that. And I think for institutions like AIIMS, which are supposed to be at the apex level, tertiary and quaternary level, where there is a responsibility. We train our resident doctors and staff to become like that, so that wherever they will go, they will pass on a message like that. So as I mentioned, this checklist, all parameters to be confirmed, checklist again, done in the ward, then in before shifting the patient to the OP, and then even before the patient comes out. So it is done at multiple moments. So again, going back. So why was it introduced in the first place? If you go through, you'll find some articles by Dr. Gawande in the US and so on and so forth in many other countries. They realized that there were certain errors which were leading to, morbidity or mortality in patients. And this is something which is preventable and correctable. So why not do our best to prevent it? And that's why it was introduced. And we were able to reduce and decrease these errors and adverse events. There are many committees and guidelines across the globe, and I think the WHO one, which is a very practical one, is the 19 FM checklist, which should be done. So this is the one, they call it, the first is the siding, where the patient comes inside the OT, before the anesthetist gives the anesthesia. Timeout is before we make an incision, and the sister again asks us everything, the nursing staff, in detail. And before I tell her, she will not allow us to make the incision. Now everything done, before the patient leaves the OT, then is the sign out. So checking which part of the patient, first of all, is the name of the patient correct? Is the site of the surgery correct? Is the planned surgery the correct one which is being done? So each and every question is there, and you just can't jump on it. So every item has a need, and I think all this has made our job easier by reducing errors. So you saw those big gadgets and all devices, they are fantastic. But the human element which shall always remain for the surgeon and for the safety of the patient as well. So error is human, but we don't allow errors in the operation theatre still. So like you cannot have a patient falling, because patient is under general sedated. So 8 people are holding the patient. Even after general the patient is likely to shake. We won't allow that to happen. We don't want anybody to fall. So that care has to be taken. So whether it is a human error, act of omission, commission, it has to be brought down to zero. That's entirely. So, but communication errors, I think with time things have improved. Doctors understand, and I think the new medical curriculum, it was the Medical Council of India, which is now the National Medical Commission, has given a lot of importance to communication. Ethics, attitude and communication. ATCOM is what they call. And that is where I think the communication, good communication, even if the patient is uneducated, you can convey to the patient. And the patient's concerns have to be addressed. So that's how we are doing. And the system has to work. There is no failure which can be allowed. Similarly, I mentioned about the equipment. It is our responsibility to ensure that all the equipments are in working condition. And if there are not, we usually keep 1 or 2 standbys along with it. So if one doesn't work, the second one has to work. So if there's one microscope required surgical, then another one available. If one laparoscope, endoscope doesn't work, there's one parallel still available. So that needs to be done. So how do we build zero events? Create awareness, and then mandatory and voluntary reporting. So you want to improve rather. So adverse events are reported. Good communication, professional fitness, competency. We keep on training. Even the so-called most trained person is also given training. So they keep on improving. Oversight organization. And again, very important is documentation, implementation, and error disclosure. Because the more open you are, the more likely to improve in coming time. So this is the checklist, special one. And whenever you have special equipment, this is a carbon dioxide laser we are using. This is a very special device, so for you have to take more precautions. Public movement is not allowed inside the operation theatre, so special ones are done. So as I mentioned about this. One more equipment that we use is a navigation. So this navigation allows us during surgery to go into the deeper areas. For example, from the nose we go towards the brain, skull-based surgery as we call it, along with the neurosurgeon. So this navigation system allows us, starting from the nose, this is a tumor in the brain. So we go from here and reach over there. So the CT scans and MRIs and all are fitted into this machine in the beginning itself for 3D. Sir knows all these devices. So 3D navigation allows us real time to know where we have reached in the depths of the skull. So, but this equipment has to work. I mean, you cannot have it not non-functional. So that part was very important. Now the notes. Once everything is done, everything is done well, we are moving towards electronic medical records, but many a times we are still having hand notes, especially when it comes to the legal aspects. And these are the notes written by my resident doctors. Each and everything has to be very neatly in a legible handwriting mentioned over there, so that even if this document is opened after 10 years or 15 years, the notes should be there in good condition. This is after the patient is through from there, has now gone to the surgical ICU. It has to be again clutter-free. You can find that the devices are there, the patients will be there one after another. It will be very neat and clean. The floors have to be shiny. You have to ensure that on a daily basis. And so that is the reason Saturday, Sunday you have to work to keep things in the working condition. So that's really the responsibility for us. So now I'll just show how we do the scrubbing. It's a small video of our doctor. Every step is important. All this became more important in the pandemic when people had to change and retrain. So you can see because directly hands is not touching anything. It's basically a no touch technique. Cochlear implantation is done for children who have lost hearing right from the very beginning. They have no hearing, and so knows it's an electronic device which will bring the sound waves, electric waves directly to the cochlea and finally to the brain. And that's how this is the small. This is the cochlear implant device which children have been implanted. This is one. Here this is one. And there's a whole group of kids, with us. We come close with them. But gratifying when all the what you strain and the stress of the OP, the post-op, the recovery. It's a huge cycle, but then it is nonetheless very satisfying. But we have to follow all the safety protocols. So the technology has helped us, but the human element will always remain, and that is why it is very interesting. So the whole operation theatre, again going back last line, is like an orchestra. We have everybody working together. The surgeon, the main conductor, like a musical note, coordination, harmony for the patient's safety and well-being. A big checklist like the pilots checking, the airlines have safety standards they have. And the operations, as they say now, is even safer than driving a two-wheeler in the city. So the safety has improved over time, and the OT adverse events are much lesser because of excellent management. So thank you very much. It's been a pleasure.